Hey everyone, so now we're going to talk about the physical assessment of the baby. Once it is delivered, we're going to make sure that our vitals, just a quick review, our pulse needs to be between 110 and 160, which is a little higher than the adult. Anything over 170, we need to apply oxygen, and that's tachycardia, and obviously it is a response of the body to compensate for hypoxemia. We need to assess that pulse femorally or brachally, not radially. And so if there's any cardiopulmonary status change or challenge, then we're going to see an increase in the infant's heart rate. Respiratory rate needs to be between 30 and 60 without any apnea. Any apnea over 20 seconds needs further investigation. We do need to apply an apnea monitor if there is witnessed apnea, and also suggest caffeine citrate. We need to keep that body temperature between 36 and 37 degrees Celsius. So when we assess the baby initially, we want to look at the color. We want to see if there's any blue extremities and pink body, which is normal at initial birth, and that's called acrocyanosis. We see that a lot in newborns, and it corrects naturally quite hastily, so we don't really have to be concerned about that. But when we see central cyanosis, that's when there is definite concern, and we need to apply oxygen and correct that. So we need to look for retractions, either intercostal, subcostal, substernal, supraclavicular. We need to note any grunting on exhalation, the baby's attempt to cause a natural peep, and that is a sign of ventilatory distress. Nasal flaring is also a sign of ventilatory distress. We need to note that. And any problems with heart sounds or capillary refill tells us that there's a problem with cardiac output. So the next thing that we want to look at is, does the child need an arterial blood gas? We don't do these often because the infant's has a scarce amount of blood, so we want to not do it conservatively. That way we don't cause any issues there. A normal PO2 is between 60 and 80 millimeters of mercury. It may be as low as 50 immediately after birth, but this should not continue for more than an hour or so. We can do special pre- and post-ductal blood gas studies to help rule out a patent ductus arteriosus. If the difference in that PO2 level from the right radial artery, which is preductal, and the umbilical artery, which is considered postductal, is greater than 15 millimeters of mercury, the infant is positive for a patent ductus arteriosus, and we may need to send to surgery for correction. Some other things that we can also assess is the chest x-ray if needed. If we see ground glass or reticular granular pattern that indicates IRDS or lung immaturity, we need to treat that with surfactant, which we talk about how to correctly apply surfactant in other recordings, so make sure that you listen to those. Transillumination is also another way that we use a bright light that we shine in one side of the chest cavity and observe from the opposite side. We look for the halo pattern, which is normal, or the jack-o'-lantern pattern, which is definitely abnormal. If the lung field lights up completely, that's the jack-o'-lantern pattern that we talk about, and that indicates that there is a pneumothorax. If only the outline of the light is observed, which is what we consider the halo effect, that's normal. Normal lungs may be described as fingers of light when a light is shined on them. If a pneumothorax is believed to be the case, we need to follow up with a chest x-ray to confirm that, and we definitely need to correct that as soon as possible. We want to check the child's or the infant's blood glucose. We want that to be greater than 30. If they are preterm, earlier than the end of the 37th week, we want the blood glucose to be greater than 20. We need to monitor this in all infants, make sure it's within range. Capillary blood gases may also be done. We want to see what may be the same as a normal ABG except for the PO2. Capillary PO2 values are not to be trusted. Simply just ignore them and look at the other clinical indicators such as saturation, the infant's color, if there's any cyanosis, any problem with capillary refill. Then we can make a care plan based on those results. But we cannot consider the capillary PO2 because it's just not dependable. So we check that to check pH and PCO2. Other assessments we can do is general appearance. We can listen to breath sounds. Any abnormality needs to be noted and a care plan initiated. Lung compliance, when we are bagging the patient, if we do that with a manual resuscitator, then if it's harder to bag, we know that the lungs are less compliant and we need to care plan according to that. Pulse oximetry needs to be monitored continuously, and bilirubin, if you see signs of jaundice, then you know there may be hyperbilirubinemia. The child may require phototherapy in order to correct that. Anytime that we are assessing the child, we also need to assess the mother. This is a major event, and they need to be assessed thoroughly and monitored as well. The mother should be assessed much the same way any adult is for adequate life functions. Make sure that they have adequate oxygenation, ventilation, circulation, and perfusion during this very stressful time. Even the most smooth deliveries are extremely stressful for the mother and the baby. We want to make sure the mom has had adequate prenatal care. If there's been an absence of prenatal care, then we know that increases the risk for the newborn and after birth. So we need to be aware of that, and we need to note that. Is there any alcoholism and drug abuse in that history that she will provide? Is there any smoking during pregnancy? We know that about almost 8% of mothers smoke during pregnancy, despite all the warnings that are available and that we see, printed in a lot of different places. And most doctors' offices have posters, and they definitely discourage the mom from smoking, but about 8% of moms continue to. We discussed earlier that the average mother is almost 26 years old, 25 years and 8 months, and anytime the mother is greater than 35 years old, then that puts the baby at higher risk for complications. RH blood incompatibility is definitely something that we need to test for and be aware of, so we can care plan for that. Preeclampsia, which is hypertension related to the pregnancy, is something that would definitely put the baby more at risk. And if there is a vaginal beta strep infection, it may be transmitted to the infant during birth. If the mom has had any previous complicated births, that needs to be noted, and the RT may need to be on standby just as a precaution. If the mother has experienced unsuccessful pregnancies in the past, then we need to definitely consider that mother and fetus to be at higher risk for complications. Remember that gravida means the number of pregnancies, including the current, and para means the number of successful viable births. So if the mom is gravida 4, para 2, then we know that she has had 4 pregnancies and 2 live births. So we need to make sure that we have that noted. Let's see. We want to assess the gestational age and physical maturity of the infant using the Dubowitz score. That's commonly used, a physical assessment of the neonate after birth to determine the true gestational age. It differs from the APGAR score. The score of 40 correlates with 40 weeks of gestation, and it's the best evaluation for moms with complications such as gestational diabetes or chronic diabetes, drug abuse, alcohol abuse, smoking history. That's a great way to assess the actual age and complication possibilities of the infant. So the ultrasound of the fetus estimates gestational age by measuring the length of the bone, which is the femur bone, and the size of the fetal skull. The New Ballard score is also used. It's similar to the Dubowitz score. It's more suitable for infants who are less than 30 weeks estimated gestational age. We talked about how that survivability is better if they're greater than 28 weeks. They can survive between 26 and 28 weeks, but they're probably going to require surfactant and some definite intervention. And then it can cause learning disabilities and other issues later in life, but there are teams available to work with that family and that child to make sure that they get the stimulation and the interventions needed to help that child live the most normal and successful life as possible. There can be the gestational age can be assessed by speaking with the mom about conception dates, but those are not very reliable. And it's also not always an honest report from the mom about substance abuse out of fear for legal issues or embarrassment or just feelings of denial or guilt. So there may be times that there is complications from exposure in utero that the mother isn't completely honest about. So be open to that, and definitely be aware that not all moms are going to give us an honest history. So, but using these tools, we'll be able to assess quickly and intervene with a care plan to give the babe the best options and possibilities. So thanks for listening. Definitely subscribe at the link below and join our study group. Thanks.